Ahi ahi Marie tātou. Good afternoon, everybody. We're just waiting for everybody to come into the room, and then we'll make a start. I'll just give it 10 more seconds. Well, good afternoon, everybody. Ahi ahi Marie. Welcome to this session with Dr. Jalal Mohammed talking to us this afternoon on developing health management and leadership lessons from the New Zealand experience. I am just going to start with karakia so that we can start this in the right way. Ka inoi tate. What a beautiful one that I like to use. Kia hora te marino, kia whakapapa ponamu te moana, he huarahi mā tātou I te rangi nei. Aroha atu, aroha mai, tātou ia tātou katoa, hui e tai ki e. Which means, may peace be widespread, may the sea be like brimstone, a pathway for us all this day. Let us show respect for each other, for one another, and bind us all together. For those that don't know me, I'm Kathy Cummings. I'm Manukura Chief Executive of the DAA Group, an accreditation agency in Aotearoa, New Zealand, and also Secretary for the Aotearoa branch of the Australasian College of Health Service Management. What a mouthful. But it is my great pleasure today to welcome you all to this session, and particularly to give a very warm welcome to Jalal, who's going to present for us this afternoon. Jalal's got a presentation. He's going to share his slides that will take about 20 to 30 minutes, maybe a little bit more, maybe a little bit less, but there will be time for questions and a question and answer session at the end of his presentation. If you would like to ask a question, then please use the Q&A box, which should be down the bottom of your screen. There's a little button that you can press on and ask the questions in there. And at the end of Jalal's presentation, I'll read those questions out to him so that we can keep the conversation going. But without further ado, I would like to warmly welcome Dr. Jalal Mohammed. Jalal is a public health and health management leader with expertise and experience across academia, research, policy, and community engagement in New Zealand, in Fiji, and the Asia Pacific region. He's a senior lecturer at the University of Canterbury and an adjunct professor at the University of Fiji, previously serving as acting head of public health at AUT and leading the health management undergraduate program. Beyond academia, Jalal holds key governance and advisory roles, including serving on the SHAPE Executive Committee and the National Council of the Public Health Association of New Zealand. He has also advised the UN Development Programme on governance, digital transformation, and sustainable development in the Pacific. Jalal founded the Pacific Online Learning and Teaching Network and is widely recognised for his contributions to health equity, capacity building, and strengthening health systems. So a warm welcome to you, Jalal, and I'll hand over to you. Kia ora.
Kia ora. Thank you, Kathy. Kia ora, everyone. Nisambula vinaka. I'll share my screen and hopefully all goes well. There you go. Just let me know if you can't see my screen, but I have shared it. So welcome and thank you for having me here. So I wanted to share a little bit. When I was asked to speak at the ACHSM webinar series, I thought about what I wanted to talk about. And something that jumped out to me was, as an academic, I've been involved in developing health management and leadership programs, but one that is of particular interest is an undergraduate health leadership or health management program. It's not too often that you have an undergraduate program. And so I thought, this would be a wonderful opportunity to talk about that and talk about some of the things that we did in that program, some of the outcomes, and what this all means, for New Zealand, but also the wider Australasian region. So it's a quick presentation. I'd love to hear your thoughts and comments. So it would be great, if we do have questions at the end of it. So I'll leave enough time for that as well. So I'm just going to cover three things in this, health management and leadership training in New Zealand, rethinking the program. So I'm going to present a case of an undergraduate program and some of the outcomes and the lessons that we learned, and some of the things that I still think that we can look at. So if we look at health management and leadership training in New Zealand, it's largely based at that postgraduate level. So we have a number of universities that offer programs in this space. So you have a Master of Health Leadership, a Master of Health Science in Health Management, a Master of Health Service Management, a Master of Health in Health Leadership and Management, and several postgraduate diplomas and certificate courses as well. So a lot of them focus in that postgraduate space. They're open to graduates, and largely the uptake of these programs has been health professionals. What there has been a gap in the New Zealand context is an undergraduate program, and particularly a program that aims to upskill and develop those lower level professionals that are in the health sector that may not have a clear pathway. So there's a number of things that led to the development of an undergraduate program. So there was, and this happened around 2014, 2015. So I'm just putting that into context. There was a lot of different calls were made. There was different government priorities at that time as well. So there was government calls to develop the health workforce with skills in health management as part of its better, sooner, and more convenient strategy. We were also seeing inequities, and we still see those inequities persist in health workforce development. So there was calls to create pathways for unskilled health workers, develop pathways for health workers from minority groups who did not have a voice in health decision making, who also there was there was a lack of representation from minority groups in health management, health leadership positions, and also that decision-making process as well. Back then, Health Workforce New Zealand, what was it? Health Workforce New Zealand also made calls for new scopes and roles for future graduates. We also had a changing context within the New Zealand setting. So we were seeing increasing aging population, increasing chronic diseases. New Zealand was becoming more ethnically diverse. There was a need for a range of health services and need for interprofessional and integrated services. So, and many of those needs still persist. Within our tertiary education sector, there was also calls for graduates who can contribute to growth, integration, and improvement of multiple health and disability services to support delivery of these as well. So those were the calls that were being made in the background. One particular university in New Zealand responded to these calls with a bachelor's level health administration program. And as I said, this happened around 2015, which was the first offering of that program. In 2017, that particular university appointed its first program lead for the program, and in university terms, that means you see viability for that program. You've run it for a few years, and you're now putting those resources to grow it further, and there will be continuation of that program. So I was appointed as its first program lead. So many of the things that I'm talking about here have also been based off my experience as the program leader. But when I took on that position, there was a number of initial challenges. There was low student enrollment numbers, so 7 students had enrolled in the program by the end of year 2. There was also issues with the program name. So the program was named as a Bachelor of Health Science in Health Administration. That health administration terminology that was used, whilst it's a developed term, particularly in North America, and it has a more defined roles and responsibilities that's associated with that term, it wasn't clear what it meant in the New Zealand context. And often what we heard back from our industry partners was that they viewed it as a program that was for low level or clerical tasks. And often they asked, why do students need to do a degree to do those tasks? So there was a lot of confusion, whilst we tried to address that, it wasn't going away. There was also when we looked at the program, we thought, are we actually responding to the health sector calls authentically? When we looked at the program, there was some missing skills and competencies in the program. And we also asked ourselves, are we serving our minority populations? It was quite theory heavy, and it lacked practical components in the program. It did have a work integrated learning component at the end, which comprised of 150 hours, but it was only at that point, when students went into that, they actually engaged with either users of health service or other health professionals. So for majority of the program, they had no contact. And when students were put into that situation, some of them struggled. So the feedback that we heard was that we needed more experiential learning throughout the program. There was opportunities to grow. So we had this program, we had it at that undergraduate level. It wasn't right, but we could work on it, we could develop it. And there's a lot of factors that, supported that development. So we had a large pool of untrained workers within the health sector. So opportunity to support workforce development and growth, to grow skills of community-based workers, our support workers, our kaifina workforce, and give them a career pathway in health. We had good relationships as a university. We had good relationships with the ministry, and there was an opportunity to piggyback on those existing relationships that we had developed across other health programs. We had our own training clinic, and it was not utilized within this program. So there's this opportunity to integrate our clinics into the program to give our students exposure throughout the program as well. We had work integrated learning. Our university had a strong work integrated learning focus with known experience and lessons that we could apply to this program as well. And the program was situated within a faculty of interprofessional health at that time. And that was also seen as an opportunity to incorporate interprofessional practice into the program and strengthen it. So the vision going forward at that point, after the, reviewing that, getting our feedback, was to develop a robust program that embeds practical skills to support the development of graduates that are future ready. So in rethinking the program, there was a number of things that were undertaken. The first one, and most importantly, was changing the name of the program. So what we did was we looked at the name, we got feedback from our graduates. By that time, we had graduates. We engaged with our industry partners. We engaged with communities. We floated the idea of a few names. Eventually, we landed, we had to look at what else was offered in the space, what other names were being used, whether it was health leadership and management, health leadership, health services management, etc. Finally, we landed at health management, and this was after consultation with all of those groups. In doing that, then we also revised the program. So we added a number of courses around health economics, quality management, emergency and disaster risk management. What we also did was we worked with the business school to offer a wider range of electives that the students could take from business schools. And this came from feedback that we received from our graduates. They made calls that, we wanted to do, it'd be great if we could do, this program could have a lot more options and electives from the business school. So we took that on board and we incorporated that into the program. We also developed a minor in health management for other health programs to take. There was also a review of the assessment, so we brought in more of that experiential learning. We brought in more of that authentic assessments into the design of the program. And we started to embed practical components across the program, in addition to that 150 hours work integrated learning capstone course. So what this looked like, for example, was the quality management course. The students actually went out into our own clinics, spoke to users, spoke to the staff there, and then came back and designed a tool for patient engagement, to measure patient engagement. And that process, we began that process and looked at other ways, other courses that could do something similar as well. We also looked at how we taught, and this was this also was it also was a flow and effect of COVID as well. What we noticed was during it was prior to COVID, but our students were changing. A lot of our students were working. They were, whilst they were enrolled full time, they were also had full-time workloads. There was calls from students to have more blended and more flexible learning options, so we incorporated it into our program. We looked at how we taught online because we didn't just want to go online. We wanted to ensure that if we brought components online, that they were engaging. So we wanted to use these tools to enhance that learning experience, to simulate some of those conversations and discussions and teamwork that would happen in a classroom environment or within, that practical settings as well. And as I said earlier, we included a lot of authentic assessments throughout the program. We used our own clinics. We had experiential learning brought in. We also had representation. So one of the things that we kept hearing from our students, and particularly our Māori, Pacific, and Asian students, was that the content didn't reflect their experiences. The content didn't actually take into account the lived experiences of minority groups, of Māori, of Pacifica. So we brought in that. We brought in case studies. We brought in examples that were reflective of different worldviews and different experiences. We also tapped in, and this took a lot of time. We tapped into a lot of networks. At that time, we had the New Zealand Institute of Health Management, which is now ACHSM Aotearoa. We worked with them to bring in some guest speakers. We did some panels and webinars. We brought in other professionals, to have meet and greet, networking opportunities, etc. And we did that specifically because we found out that from our graduates that there was a lack of professional identity. And this exists, and this is a wider conversation, within the New Zealand context, probably less so within the Australian context, is health leaders, health managers, lack that professional identity that within the health sector that doctors, nurses, or other allied health professionals have enjoyed. So that was something that we knew. That's not something that we've solved within programs. I don't think any program has, but we did incorporate all of these networking activities to give students, some of that identity, that they would have. And as I said, we had learned from that COVID experience. So we had learned what works well within online teaching. And we didn't want to do, we didn't want to use the online space is just as a repository. We wanted to make it engaging. We wanted to ensure that students have a positive experience online. So we worked really hard, as we brought in blended approaches, as we brought in online courses to ensure that students had that opportunity, that it was engaging, that they had meaningful experiences, meaningful learning experiences. And one of the things that we also understood, and that we began to understand, is we wanted to really know who was it that um, was taking the undergraduate program. And I'll talk a little bit more about what we found out. But we wanted to know who our learner was. And then, we wanted to develop the program or our teaching approaches, our pedagogy to ensure that we are best delivering to that cohort of learners. And I'll give you an example. This is from another study that I'd done in the Pacific, and it was around developing training programs for civil servants. And it's just finding out, who are the learners. It was, in this case, it was, they all had about 4 to 6 years of work experiences. They preferred blended approaches. They had already undertaken online learning. They preferred team learning, discussions, presentations and multimedia resources, and preferred facilitator engagement and support. So it was understanding that learner and then developing resources and developing the program and developing support mechanisms around the learner as well. And that worked really, really well for us. And, we had a lot of support services for undergraduate students, and this is something that, if you're developing a postgraduate health management and leadership course, that you probably don't need to think about at that level. But at an undergraduate level, you needed to have all of these resources. So the program leader role was central. The program leader met with the students, talked about their pathway options, courses that they could take, and this happened once a year. So they actually felt like, there was someone there that was looking after them. There was someone there that was engaging with them and supporting them throughout their study, and someone that they could turn to. Because what we didn't want was, students to not feel like that there's no one there that they could go to. And then when that happens, we know that students, particularly students from our minority populations, would drop out of the program. We also embedded a lot of wraparound services, and also services that supported soft skills, developing CVs and interviewing and networking skills in their final year of study. And we also had all of those mechanisms for professional identity that we talked about. So before I go into that, I just wanted to talk to you about who our students were, who were taking an undergraduate health management program. So 90% of our students were women. Majority of the students that enrolled in the program were between 20 and 29 years of age. And unlike any undergraduate program within the university, majority of our students were from the Pacific population group, followed by European, New Zealanders, Asian, and then Maori students. Around 3/4 of our students spoke an additional language other than English, and a significant portion of those were first in family university students. And so we saw, once we made those changes, we saw that our Māori and Pacific students increased in numbers. So our Māori students went, to having no Māori students in 2015 to 8% of the total enrolled students of the program were Māori. And similarly with Pacific students, 36% by 2020 were of Pacific heritage. We also increased our work integrated learning organization. So we had 3 in 2016 to over 15 different choices in 2020. We had 92% of students or of graduates reporting employability post-graduation. And this was a graduate destination survey that was done a couple of years after the first batch of graduates. I think we had 3 batches of graduates that had been sent that survey. So of that 90, 2%, 75, percent of the respondents were in full-time employment, and 17% were employed part-time, 8% in further study. We had graduates across the health sector, what was then district health boards, in primary health organizations, in private organizations, and non-governmental organizations as well, and a number of different roles such as quality coordinators, team leaders, practice managers, complex care coordinators. All of the graduates that were surveyed had permanent contracts. Majority earned between $45,000 and $65,000 per annum. 90% of our student cohort were local students. So it was really a program that served the local market. We had about an 88% retention of students, and that was because of those wraparound services that we provided. So which was really good, to have such a high rate of students completing the program. And when we did our graduate survey, 82% of our graduates found the program very relevant to the roles that they were performing. And, there was a number of things that graduates highlighted, and, they highlighted developing those practical and work integrated learning opportunities. Interestingly enough, graduates said, we wanted more. We thought we had quite a bit, 150 hours, but they all recommended, increasing that. There's something that we did not take on board just because of the logistics of doing that, but we did incorporate experiential learning in our other courses in the second year. And a number of graduates said a number of different things, around the course. I won't read all of that, but, they all touched on placements. The course had, throughout the program, we talked about health inequities within the health workforce. That was a strong emphasis in the program. So, that stood out to students. A lot of students, because we developed those online resources, they found those lectures, tutorials, the videos, and all of those online resources quite engaging. So some of the lessons that we've learned, from that development at an undergraduate level, and I think it's quite important because we don't have many undergraduate health management programs. I don't think Australia has any, but someone can correct me if I'm wrong. And there are few undergraduate programs within the Asia Pacific region, but not many. So the New Zealand experience is quite useful in determining, could we be doing this in other countries? Should we be looking at undergraduate health management programs to develop and upskill those health workers who may not have qualifications, who may not have a career pathway? So, we learned a number of things. We learned that we need to review and revise the program to keep it current and relevant and aligned to national needs and produce graduates that are future ready. It's important that we do that with our partners, so industry partners, but not only industry partners, but to work with our community partners as well. We need to support those revisions with data. So supporting the revisions with graduate surveys, enrollment rates, retention and attrition rates, course evaluations, annual reports and program reviews to give us a comprehensive picture of what is working and what isn't working. Too often, and being in the higher education sector, we sometimes think that programs are great. And, in this case, we thought, okay, let's develop a program in health administration. And someone thought about that and thought that was a great idea. But when we actually did it, it didn't work. It wasn't, contextual to New Zealand. So sometimes, well, sometimes some of the programs in the higher education sector probably isn't supported by as much data as we should. It's important, as I said, that we co-design with stakeholders. It's important to include those community stakeholders. So to consult with Pacific and Māori populations, to consult with our Asian populations. Often we consult with industry partners, we consult with professional bodies, but we do forget about those community stakeholders. So that was something that we learned from this program, that it is important to go back to communities and get their views as well. It's important to align programs and courses with national priorities. And support the development with sound pedagogy. And I know universities are strong at doing this, but that pedagogy and how students learn has changed as well. So it's important to go back to also thinking about who your learners are and what is the most appropriate pedagogy for the changing needs of learners. And learners have drastically, as I said, changed since COVID, and the contextual differences. Is particularly here, I've moved universities in New Zealand. What our learners are quite different in Auckland and say where I am now in Christchurch. There's a lot more contextual differences, socioeconomic differences. A lot of our students in Auckland were working so to support themselves and support their studies and their families during that period. So it's important to understand regional differences as well. It's important to create that space for innovation. And I was lucky enough that, at this particular university, it was a young, new university. At that point, it's probably still is within the New Zealand context. But there was a lot of opportunities to be innovative, a lot of opportunities to try different things, and a lot of encouragement to try different things and revisit them if they didn't work. So it is important to create those spaces to be innovative, to try new things, and to have a culture where if it doesn't work, that we can relook at it, we can revisit it, we can try things, and we can, try to make it better for our students. As I said, those practical, that experiential learning was quite important. And we learned that students want more of that. They want to be able to put their theory into practice. And I think that makes them better for the health workforce later on. So that is something that's quite hard to do. We do need industry partnership. We do need to see how we can work together. And this is something that I still haven't, fully overcome, because it isn't easy to create those industry partnerships. And I don't think it is for any university, but I think there needs to be more collaborative work done with universities and the industry to ensure that our graduates are going to meet the needs of the industry. we need to support students. If we don't support students, they're not going to succeed. We're going to see high attrition rates, particularly for our minority populations, our Pacific, our Maori students. There needs to be a lot more support. And part of that is also ensuring that they see themselves within that program as well. We also need to create a professional identity. I'm not sure how to do this within an undergraduate health management program or within that New Zealand context where there isn't a strong health management identity, not as strong as Australia. So I think this is something that we've talked about. And this is something that, that is a work in progress. There also needs to be within the university systems, administrative and leadership support for programs, for program development, but also administrative support for, if you want to partner up, someone to look for those partners, someone to ensure that new networks and new agreements and all of those things are developed continuously. So at the end of that, those are some of the things that we learned. But at the end of that, I still had some questions, and I still have some of these questions, around how do we work better? How can academic institutions and healthcare systems collaborate more effectively in leadership development? And how can academic programs better prepare graduates for the realities of leading within complex health systems? These are questions that I ask myself all the time. How can we collaborate with between industry and higher education to embed experiential learning opportunities in health management and leadership program? And what emerging skills and competencies would future health leaders need? And what courses and programs should we be developing to meet those needs? So those are some of the questions that I still have at the end of this process. And if anyone has any comments on that, I'd love to hear it. So I'll open it up to any questions. There's a little barcode if you want to connect with me post this webinar and continue the conversation. I'd love that. So you can just scan on that and you'd be able to find my contact details. But over to you, Kathy.
Thank you, Jalal. Vinaka Vakalivu. Kia ora, ngā mihi nui. Thank you very much for those great thoughts. I really enjoyed the presentation, and it told a lovely story, Jalal, which was really great to hear. At this stage, oh yes, we do have one question that's come in. This person would like to know more about the integrated clinics, Jalal.
Right. So this particular university doesn't have, I might stop sharing so I can see, yep, there you go. I can see you now. So this particular university that I worked at had an integrated clinic. There was about 7 different clinics from podiatry, physiotherapy. So they were all allied health clinics that was located near the university that was frequented by people with people from the lower socioeconomic group because it was very cheap, but also a lot of elderly people. It was a great clinic. They don't actually have that anymore. And what we did with the health management program was we worked with the clinic, had our students at the clinic on a weekly basis. They had I mentioned about that quality course. So they had a lot of users coming into the clinic. They had conversations with the users to understand what would be, what would they respond to, what sort of tools, if we were to get feedback, what would work in their context, what wouldn't work. So they kind of had those conversations to understand what tools that they could use. They had conversations with the health workers there and then designed those tools. So, it was a lovely clinic. Unfortunately, it doesn't exist, but so a person would come into that clinic with, say, diabetes, and as a result, had complications on their feet, and they might need some other service as well, so they could visit a number of different services in that clinic.
Fantastic. Thank you. That's a comprehensive answer to that question. While we're waiting for more questions to pop in, I have a question for you, Jalal. At lunchtime, I was talking with one of my younger employees who tells me that it's possible that AI might be Time Magazine's Person of the Year this year, which is kind of not surprising, really, isn't it? Because AI is what you hear in conversations personally and on the news and in documentaries and so on and so forth. Like, it is having a massive, massive impact on pretty much all aspects of our lives, or many aspects of our lives. So my question is, how can programs such as yours further integrate emerging technologies like AI, but other digital health systems into their curriculum to better prepare students for the future health workforce?
Excellent question. It's not something that we as universities have grappled well with at the moment. We know, there's certain types of assessments that don't work. So, if you had a written assessment that's an essay format, AI would do it for you. It's getting a lot better. It could do a better job now than it did a couple of years ago. But it is around, and I'm a believer that you have to integrate these into our programs. If you don't, you don't prepare students well, students are going to use it, whether you say don't use it or, use it. I'm of the view that let's use it and let's prepare them on how they can use it ethically. No, we explore a number of ways. So we ask them to generate, we might give them a question and ask them to generate an answer to that using AI, and then ask the students to critique that response. So they go in and then they do their research and they critique the answer that AI has given them. So in that way, they can tell, this is right, this is wrong, because AI often picks up things that are wrong, that are not contextually relevant as well. So they're able to, when they're critiquing that, think about those things as how relevant is this to our population, to our health system. Yeah. So we do use it in that way. Yeah.
I thank you for your answer, and I think that's probably something every single educational institution around the world is grappling with at the moment. And I like that you're looking to embrace it and use it in a positive way rather than forbidding it, because we know that prohibition doesn't work. So and people are going to do what they're going to do. So really great answer. Thank you. There is another question that's come in, Jalal. This person thanks you for your presentation. Typically, what roles in health services did your graduates start in? Was it only in hospitals? Was it only in primary care? What was the breakdown?
So we had care coordinators. So it was in all across primary care, hospitals, public, private, non-governmental organizations. We had them in roles such as got them written down here. We had quality coordinator, care coordinator, clinical records administrator. Now, I can't tell you because this was done at a particular point in time, and I think we had about 3 lots of graduates by then. It didn't ask whether they were initially in what role they were initially involved in post-graduation. It just asked what role are they currently employed as. So I'm not able to say, if they had moved up. I know I followed with a number of our students, and a lot of them have done quite well to go on to, 5 years later, 5, 6 years later, one of them is a national manager. So of course they've had subsequent educational opportunities and training following this program as well. But it gives them the pathway. These weren't clinical staff. They weren't doctors or nurses. They weren't allied health staff, but they do hold that leadership position. Yeah.
Fantastic, thank you. This question came from Sharif, and he has a supplementary question, which is, was there any feedback from employers on the skills that the graduates developed?
Sharif, there possibly could be. I'm no longer at that university, so I'm not privy to that. So unfortunately, I can't answer that question. I since have moved to a different university. I'm sure there has been some.
Mm.
Yeah.
Thank you. And Janet asks, I was a little disappointed to hear the per annum salaries after achieving the qualification. I think there was, we're talking late 2010s, weren't we, rather than today. And maybe think salaries have moved on, but
They would be
have you got a
about
comment?
20. I think it was done about 2019, this survey. Yeah.
Yes. Okay. So any comment on that salary level?
That was the majority of them. Some of them were earning, so I did make a note here. Majority earned between 45 and 65,000 per annum, and a small number earning more than 80,000 per annum. Yeah, I mean, it is a little bit on the lower side, but these were blocks, so I couldn't give you detail whether they were earning 45,000 or if they were earning 46,000 or if they were earning 64,000.
Yeah.
So
I'm assuming there could be a part-time component to
yes,
it as well.
yeah.
Yes.
That probably has changed in the last 5 or 6 years as well.
Thank you, Janet. I hope that answers your question. One more question from me, Jalal, which is, there's a lot of change occurring in our health service at the moment, particularly for those who work within Te Whatu Health New Zealand. A lot of rapid change occurring, actually. And in line with that, what gaps do you see in current leadership and management training, and what strategic shifts might be needed to ensure future leaders are equipped?
Right. So it is around digital health and AI. This program, I followed along with this programs from the sidelines, hasn't done any further revisions. So it is what those revisions were, and times have changed, needs have changed as well. So I think that digital health and AI aspect could be incorporated into programs. As far as this program went, it focused on health records. So it left it there, and I think there is an opportunity to take that further now. And I think that a similar comment could be said about many of the programs, that there is a lack of digital health in those spaces. And I know the college has added digital health, so I think we will see more programs incorporating that into the curriculum. I think incorporating those business pay courses worked really well for us. It meant that we didn't have to develop those courses. And I know graduates, it gives them an opportunity to sit and have those conversations with people that are not in the health sector. And I think that is particularly useful. So when they took those papers, they were surrounded by students who weren't gearing up to be in the health sector. They were going to go and do, other things. So having that conversation and learning from them is important as well. And I think more of those opportunities need to happen within health management programs as well.
Fantastic, thank you. I mean, it's the world is moving at such a fast pace, isn't it? And it's not just health, but it's education and it's everything else. And so being able to rapidly move and update is important. So great to hear about that. I wonder, we don't have any other questions, Jalal. Are there any further comments you want to make before we close?
Yeah, I think we have an opportunity as educators. Too often we're not working with industry partners, and that is a criticism being in the education space. I think we need to do a lot more of that. And I know our industry partners they're quite busy, so it's hard for them sometimes to have those conversations with us to make time. But I think more of that needs to happen if we are going to have programs that respond well to the needs of the health sector, because sometimes you could have programs that haven't changed in a decade and they're still teaching relatively the same thing that they taught 10 years ago. But to have those collaborations, to have the feedback, to have mechanisms that continually help revise and grow those programs, to revise the content, is something that we should be doing. How do we do that? I'm not sure, because it isn't always easy. But we do need to work together to ensure that we do produce graduates that are going to be ready for the workforce. And I think it's in everyone's interest if we do that. But I'm looking at answers from everyone else. How do we better do that? Yeah.
That's a challenge that you've put out there. So fantastic, something for us all to think about. Thank you again, Jalal. Vinaka vakalevu, ngā mihi nui, mō te pānui, mō te whakaro for your thoughts and for your presentation today. Thank you. I trust that it gave food for thought to those people that are online, and perhaps it has piqued an interest in exploring further the offering that you've explained to us today. The Aotearoa branch of the college had met all day yesterday to do some strategic planning for the year coming, and Jalal was there with us as well, and it was fantastic to have Jalal there as our newest board member to contribute his wisdom to our discussions. And we've got great plans ahead for our New Zealand members, some great value add. So watch this space, because there's really good things coming. Just a reminder also to everybody that we are in the nearing the final stages of planning for the one-day conference, ACHSM Aotearoa Branch Conference that we do in partnership with RACMA. You might recall that this is the one-day conference that alternates between Melbourne one year and Aotearoa, and in particular Auckland the next. So it's our turn next year. This is going to be on the 13th of March, so you might want to put a save the date into your diaries now. For that, it will be at the Cordis Hotel in Auckland on the 13th of March. The early bird notifications will come to you very soon, so we would encourage you to sign up for those pretty quickly, because it was a huge success when we held it in 2024. Sold out. So do put that into your diaries and register as soon as you can to avoid disappointment. Also, just a reminder, I know we've just had the ACHSM Congress up in Darwin, but we are already planning for next year. The date is set. It's going to be the 28th to the 30th of October, and it's going to be in Cairns, lovely Cairns, nice warm place to go at the end of October. So put that in your diaries also. But on that happy note, I will thank Jalal once again for his wonderful presentation, full of fantastic thoughts for us to take away at the end of this Thursday. I am going to finish with karakia, but before I do that, I'll wish everybody a good rest of the day. Kia pai tō rā tātou. Let's all have a good day. Ka anoi tātou, e te atua tēnei te mūtanga, kua mutu toroanga, kua mutu te kaha, kua mutu te mahi nei, kua pai, haumie, hui e, tai ki e. Which means let the universe know that this is the end, the long journey is done, the effort is finished, the work is over, all is well. Let us bind together. Ka kite anō koutou, let's see you all again.